Speaker and represent again Professor Hatem Abdulazim. And may I just add to everything that was said before, that he is actually belonging to the bigger family of the NCI, and we're all very proud of him. And he will be discussing breast cancer during pregnancy and pregnancy following breast cancer.
Well, it's certainly my honor to say that I belong to the family of the National Cancer Institute, and it's a real pleasure to have you as a chairperson too in this session. Okay. So, I hope you didn't have enough of me yet, so we still have 20 minutes on this talk. So in the coming 20 minutes or so, I'll be covering the topic of breast cancer and pregnancy, and I'll start with breast cancer during pregnancy, and indeed the breast cancer appears to be the most common tumor diagnosed during pregnancy. I'm saying appears because it's pretty much, we don't have really very large registries to estimate accurately what are the tumors diagnosed during pregnancy, but several studies have suggested that breast cancer appears to be indeed the most common tumor diagnosed during pregnancy, and the incidence appears on average to be on the rise. And indeed, this situation is faced with several medical and even ethical issues, because it's true that maybe potentially the treatment you'll be offering to the mother could be potentially hazardous to the fetus. Okay, so can we go on? Can we go on? Okay. So I'm going through a clinical case, and through this case we'll be pretty much addressing several clinically relevant questions, in my opinion. So this is a case of a 36-year-old pregnant lady with no previous pregnancies, had a 12 week of gestation, a painless lump in the left breast. She performed an ultrasound, which is certainly the modality of choice in pregnant patients, and showed a 22 millimeter speculated nodule, as you can see here on the image. And the biopsy revealed invasive ductal carcinoma, grade 3, triple negative with a high Ki67. Indeed, as well, these tumors are classically aggressive, and triple negative is relatively common in tumors diagnosed during pregnancy. So when we are faced with a patient like this, we pretty much have I would say few questions in mind. Well, that would be whether we opt for termination or not, what's the actual role of surgeon radiotherapy and the safety of systemic therapy, and whether we go or not for premature delivery. In the interest of time, I will not really be addressing the issues related to prognosis and biology and imaging, but I'll be happy, of course, to receive any questions if you have any in these aspects. So talking about abortion or inducing abortion, and there is frequently a term used which is therapeutic abortion, and I'm not sure really this is a very precise term, because I'm not sure that abortion at all in these patients have any therapeutic role, although we don't have really a lot of studies that looked into that, but this is just one of very few ones that we have performed actually, and you can see here the difference in disease-free and overall survival according to whether the patient completed pregnancy to term or had a preterm delivery or had an abortion. And you can see clearly that there is no impact whatsoever that preterm delivery or inducing abortion improves the outcome of these patients. So here the question actually lies whether we are really comfortable with offering adequate therapy during pregnancy, yes or no. And here I'll start with surgery, and I'm referring here to the very recent ESMO guidelines on managing cancer during pregnancy that was just published a few months ago, and going through the different aspects of surgery, and it clearly states that decision to proceed for mastectomy or conservative surgery should follow standard practice as in the non-pregnant setting. So again, diagnosing during pregnancy per se doesn't mean that the patient should perform one surgery or the other. They can be performed pretty much throughout the gestation period, and sentinel node, although there is very limited data on sentinel node during pregnancy, however, there has been some what we refer to as dosimetry data and dose estimation data to see how far really there is a high uptake of technetium when you inject technetium in the axilla at the site of the uterus. But the clinical data only relies on a very small study done at the European Institute of Oncology in Milan, including only 12 patients, and you can see clearly that, and we had a follow-up of nearly 3 years with no axillary recurrence and normal development of the fetus. To my knowledge, this data is currently being updated to 50 or 60 patients and will be published later this year. To my knowledge as well, that the same data still exists, that there is no real complications on the babies, and the data for the patients is pretty much in line with what you expect with these kind of procedures outside pregnancy. Another point that we need to consider is adjuvant radiotherapy, and it's, I would say this was an area of debate, although I would say the vast majority, including myself, would really say that adjuvant radiotherapy per se is never an urgent procedure, so you can always better postpone it until delivery. Nevertheless, I would, just for the sake of clarity, I would like to say that others believe that, maybe you can deliver it early in pregnancy. In my opinion, this is pretty much not the best situation to consider. However, this needs to be taken in mind when you plan as well the surgical treatment. For example, if you consider breast conserving surgery, for example, during the first trimester, you need to understand that maybe you are delaying radiation too much if you want to delay it after delivery, and maybe in this case you need to really consider maybe other surgical modalities for these patients. So this kind of discussion needs really to be performed. But nevertheless, in my opinion, adjuvant radiotherapy should preferably be always deferred until delivery. Moving to systemic therapy, and indeed the issue with systemic therapy that when a drug is administered to the mother, placental transfer of the drug could be potentially hazardous to the fetus. And in this cartoon, you can see the different developmental periods of the fetus, and indeed, of course, exposure to drugs during the first and second trimester would be a problem. It would be associated with a very high risk of congenital malformations reaching up to 20%. So when we look into what kind of transfer these chemotherapy, whether chemotherapy transfers to the fetus or not, and this is a very interesting study that was done on baboon models and on monkeys actually, where different drugs were administered to the mother, and this is here you can see in the numbers. So these are the number of patients here, or the number of monkeys actually, and this is the drug was detected in the fetus of these baboons. And you can see, for example, when you inject doxorubicin, for example, it's detected in the fetus, it's 6 out of 15, and the percentage of the drug is 7.5%, the concentration of the drug that was in the mother. So the concentration, and the same for opirubicin, you can see clearly that, for example, the likes of taxanes appears to be relatively less detected in the fetus compared to when you compare, of course, to the whole concentration of the mother. So this is, in my opinion, rather reassuring, although we do not really know what does really 4% or 7% mean, but they, on average, particularly when you consider taxanes, they appear to be relatively acceptable. One of the interesting things as well, that after they took out the fetus and they looked into different organs, and one of the issues of administering, for example, anthracyclines is always cardiotoxicity. So they looked into the concentration of doxorubicin and epirubicin in the fetus, and actually the fetus here is represented by white blocks, and here you cannot see white rectangles at all or white blocks at all in the heart, which indicates that they did not detect at all either doxorubicin or epirubicin in the heart of the fetus exposed in utero to anthracyclines, which is again rather reassuring. But let's look at the clinical data. So this is a summary of the most, in my opinion, important studies looking into different regimens in breast cancer diagnosed during pregnancy. You can see here the number of regimens and the number of patients. All of these regimens were starting as they should during the second trimester, and all were pretty much, we had a median age at delivery at term, which is very much favored, and with no increased risk of malformations when you compare this to what you expect in the normal population, which is again rather reassuring. However, I would like to draw to your attention that on average, patients receiving chemotherapy during pregnancy have on average, an increased risk of pregnancy complications. So you do have more, for example, obstetric complications, more premature deliveries on average, more fetal weight below the 10th percentile, which call that maybe in these patients, while we can try to adapt standard strategies, but maybe we need in some situations to adapt some tailored strategies, some modified strategies. And one of the things here that I'm referring to particularly is the weekly application of chemotherapy. One of the most advantages of the weekly application of chemotherapy during pregnancy that it allows you to have a very close monitoring of pregnancy. It allows low peak plasma concentration of the drug, which again lower than a DIR period pretty much, and lower the toxicities in general, and possibly lower the placental transfer of the drug too. And of course, when you give the drug on a weekly basis, you can easily interrupt the drug if you encountered any toxicity, not like when you give it every 3 weeks. And this is just an example of a study that we started a long time ago, and we now have follow-up data on these kids, where we given weekly ipirubicin. The drug was very good, well tolerated, and we do have by the patient, and as well we did not observe any major complication for the newborns. One of the most important things is the long-term cardiac outcomes of these patients exposed to anthracyclines in utero. And this is a very interesting study from the group of Leuven in Belgium, where they looked into studied children, and what they mean here by studied children, that children were exposed to anthracyclines in utero, and controls, which are children not exposed, of course, to any chemotherapy during pregnancy. And you can see here that while on average the fraction shortening and the ejection fraction was in the normal limits in both groups, it was indeed lower in patients, significantly lower in patients exposed to anthracyclines in utero. I'm not sure how clinically relevant is this, but indeed this is something we need to consider in mind. This wouldn't really stop me in advocating anthracyclines during pregnancy, in my opinion. However, this needs longer follow-up. The values are still in the normal range, but it seems that there's some level of affection that happened to the fetuses exposed to anthracyclines during pregnancy. Taxanes, relatively less data with taxanes. However, they are again pretty much reassuring, in line with the data I showed you before in the animal models. They appear indeed to be crossing at a lower rate to the fetus compared to other drugs. A word of caution concerning trastuzumab. Indeed, trastuzumab administration during pregnancy increases the risk of oligohydramnios and premature delivery. And you can see here, this is a summary of the cases reported in the literature so far. You can see clearly that there is an increased risk of oligohydramnios, which predisposes to premature delivery and as well fetal mortality. So clearly trastuzumab should not be given during pregnancy. The same case applies for tamoxifen. Again, this is a summary of cases that has been exposed to tamoxifen during pregnancy. I'm highlighting for you the different syndromes and malformations that has been reported even when the drug is given following the first trimester. And indeed, a lot of ambiguous genitalia has been reported. So again, tamoxifen should not be given during pregnancy. A word regarding premature delivery, and in this case I would like to draw your attention to the drawbacks, very serious drawbacks of premature delivery. And I'm referring to this because it's frequently encountered in the oncology field that if once the mother have reached, you can deliver the baby, maybe it's better to get it out. I'm not sure that you are doing a very good favor to the mother and to the baby when you do that, unless of course there is an urgent medical indication to do it. But if the pregnancy is proceeding well, in my opinion, you need to push it as long as possible to term, because you can see here clearly that even when you deliver late preterm, which is week 34 to week 36, you still have a significantly higher odds of developing cerebral palsy and mental retardation in these babies. So we need really to be careful about the decision to go for a premature delivery. And you can see here, and this is again from the group of Leuven, that, and this is in patients with breast cancer, with cancer during pregnancy, you can see that every week, every additional month of gestation is associated with improvement in the IQ of these babies. So again, this is very important to be considered. So my take-home message of this part of my talk, that indeed there is no role of pregnancy termination for therapeutic purposes. Of course, some patients, you would have to do therapeutic abortion for them. For example, if diagnosed with a very aggressive disease very early in the pregnancy and you need to interfere right away, maybe here you need to think about it, but you need not to advocate it for therapeutic reasons. Surgery should follow as clinically indicated in the non-pregnant setting, and it's always better to postpone adjuvant radiotherapy to the post-operative setting, to the post-delivery setting. Chemotherapy should start with the second trimester. You can go with chemotherapy up to week 34 of gestation. This is acceptable. Classic anthracycline-based regimens are safe. Weekly regimens are really encouraged. Avoid trastuzumab and tamoxifen. Premature delivery, you should, in my opinion, do as much as possible to try to avoid it unless it's really medically indicated. Moving to the second part of my talk, which is about pregnancy after breast cancer. And indeed, when you look into cancer survivors in general, you can find clearly that among cancer survivors, breast cancer survivors have the lowest chance to be subsequently pregnant. For example, when you compare them here up to the survivors of thyroid cancer or melanoma, they do have pretty much high chance of becoming subsequently pregnant, while breast cancer on average have a 70% lower chance of becoming subsequently pregnant. And I think this is particularly for a main situation. The situation that you do have a patient, actually not a patient anymore, you do have a breast cancer survivor that's asking you the question whether it's okay to become pregnant or not, and you have the physician that is not always very comfortable, because maybe the pregnancy and estrogen stimulation and so on maybe is not a good idea for a patient, particularly patients with a history of endocrine sensitive disease. And this has resulted that while different surveys suggest that from 30 to 50% of patients are willing to become pregnant after breast cancer diagnosis, the real fact is that only 5% of these patients become pregnant. So here I'll be trying to address key issues regarding the safety of pregnancy, particularly in ER-positive patients, whether there is a role of abortion, when to become pregnant, and again, whether we can interrupt endocrine treatment to allow pregnancy. Is this an acceptable approach or not? So this is a meta-analysis, which is nearly 3 years old now, was looking into the old studies that looked into the different studies addressing the safety of pregnancy after breast cancer. As you can see here, actually, there is 0.59 relative low, so there is a lower risk of death in patients becoming pregnant. I'm repeating this again. So patients who became pregnant after breast cancer diagnosis had a reduced risk of death. So this is pretty much against the conception we have that pregnancy is bad. On the contrary, at least these studies suggest that pregnancy is good. However, these studies had major limitations. One of them is what we call selection bias, which means that it's indeed for a patient to become pregnant, she has to be free of relapse. So maybe here we are not really comparing pregnancy versus no pregnancy, we're just comparing no relapsing patients to potentially relapsing patients. Another thing is that none of these studies address really the question in the ER-positive population, which is actually the population that are mainly concerned about. None of these patients had any information on ER-positive status. It wasn't clear really when it's safe to become pregnant. And these studies reported up to 30% of patients had an induced abortion, which means two things. First, there is a conception that pregnancy is bad. Second, there's another conception that abortion could improve outcome. Both not supported by evidence. So this is what we tried to address in this study, which we published last year, which we tried to address the limitations of previous studies. So we included patients who had a history of breast cancer, who became pregnant after breast cancer diagnosis, and we matched them to patients who did not become pregnant but had the same ER status, same nodal status, received pretty much the same therapy, and importantly, they were free of relapse at the time of pregnancy. I'm just here showing you that we included more than 300 patients who became pregnant after breast cancer diagnosis. Importantly, nearly 200 of them were ER positive. And again, here you can see on the slide that 40% of these patients had a node-positive disease. And this is the primary endpoint, disease-free survival in ER-positive patients. Clearly, median follow-up of 5 years, clearly no difference in outcome in whether the patient became pregnant or not. Again, you can see here when you consider the whole population, meaning ER-positive and ER-negative patients, no difference in outcome as well. When you look into the time to become pregnant, we compare the outcome in those who became pregnant during the first 2 years and those who became pregnant later. Again, no difference in outcome, although this was a subgroup analysis. We looked into the impact of abortion, so meaning whether abortion improves the outcome, yes or no. Again, it does not improve the outcome at all. Fetal outcome in breast cancer survivors, well, this is less of a concern when you compare it to managing breast cancer during pregnancy, but I think it's still a relevant point. So here again, the slide is not working, but I can tell you that it's okay. Breastfeeding, very limited data on breastfeeding. Again, we did not observe any difference according to breastfeeding status. However, there's a major issue when it comes to feasibility, particularly from the ipsilateral breast, so the previously operated and previously irradiated breast, in which we do have a considerable, okay, time up. Okay, I'm finishing. Should have done like Ricardo and brought my own computer so that I don't run to that.
Hatem, you have like 2 minutes.
Yeah, I'm done.
So it's okay.
So as I was saying that for breastfeeding, it's the main issue is feasibility, particularly from the ipsilateral breast, where there's always a problem in milk production, which is pretty much reduced in up to 50 to 70% of patients. Nevertheless, breastfeeding is feasible always from the contralateral breast, which means the previously not operated breast. Finally, regarding the question is the concerns about feasibility of pregnancy after 5 years. Sometimes it's a big deal for some patients to wait until 5 years of hormonal therapy to become pregnant. Sometimes too late for them. And according, the question always arises, can we really interrupt hormonal therapy to allow them to become pregnant? And indeed, this is a very tricky situation, and we don't have any data to support that this is a safe approach. But as you can recall from the previous presentation, that the compliance of breast cancer patients to hormonal therapy is very poor. So even if you tell her that you should not interrupt therapy and you should wait until 5 years, and if she really wants to become pregnant, believe me, she will interrupt hormonal therapy. So this is actually, from this, we started a large international effort by the International Breast Cancer Study Group and the Breast International Study Group, looking into this particular question, in which we are including patients who had surgery and received adjuvant chemotherapy and received at least 18 to 30 months of endocrine therapy, and they are willing to become pregnant. So we are including this patient in a study where we offer them to stop endocrine therapy to allow pregnancy for 2 years and then resume endocrine therapy afterwards. And the main primary endpoint here is looking into the effect of this on the risk of recurrence. Of course, this is not an easy study to do. It needs to have a patient that is really willing to become pregnant, and it's a validation of the concept how far really we are. The patient needs to understand that this approach can increase the risk of recurrence. Probably, maybe, we don't know about this. But if she's really willing to become pregnant, then maybe we can look into that. And well, this study as well will have a very extensive translation research program as well. So in conclusion, regarding the effect of pregnancy on the risk of relapse in patients with history of ER-positive breast cancer, indeed, pregnancy does not increase breast cancer recurrence, even in patients with history of ER-positive breast cancer. Of course, it's optimal to wait until adequate completion of adjuvant therapy. Regarding the timing, I don't think it does matter much when to become pregnant, especially here I'm referring particularly to ER-negative patients in which after chemotherapy they are pretty much, they don't have any therapy to complete. However, maybe conventional wisdom would suggest waiting at least for 2 years. These 2 years are associated with a relatively high risk of recurrence, so maybe you would be more comfortable, the patient will be more comfortable that she bypassed this period. Also, it will allow the ovarian function parameters to recover well. Abortion does not impact prognosis at all, and hence it should not really promote it for therapeutic purposes. And thank you very much for your attention.
Thank you, Dr. Hatem. I think we can allow only one question.
Yes, please.
Can we have mic here?
Yes, please.
Thank you for a very nice presentation, Dr. Hatem. I want to ask you about your experience about female patient to develop pregnancy under hormonal treatment. What's your opinion?
Well, I think the issue of, and unfortunately I wasn't able to cover this in my talk for the interest of time, but the issue of getting pregnant on maintenance therapy in general, tamoxifen, trastuzumab, is always possible. And we tend sometimes to forget to advocate for contraception after chemotherapy, and sometimes the patient resumes menses on hormonal therapy and so on. The case for tamoxifen is indeed, I would say, relatively serious, because tamoxifen, as I've shown you, tamoxifen indeed is associated with a very high risk of congenital malformation. So here we are saying that a patient that you discovered that she is had an amenorrhea for like 7 or 8 weeks, so she has been pregnant for like 3, 4, 5 weeks. So accordingly, here the patient should understand that it's possible that there is a risk of malformation after exposure to tamoxifen. You can wait until week 12 and do really an ultrasound with some testing to ensure whether you do have a congenital anomaly or not. This is indeed a risk that the patient should understand. I wouldn't say that we should always rush quickly to do abortion in this patient. We should wait, but indeed investigate early on whether there is a congenital anomaly or not. And this is indeed possible nowadays. Regarding trastuzumab, the situation is pretty much different, because trastuzumab is a large molecule. It does not really cross the placenta early in pregnancy. So even if the patient, while I've shown you that trastuzumab is associated with a risk of oligohydramnios, this is pretty much after week 14. So when you electively administer the drug from the second trimester. In this case, the patient became pregnant on Herceptin. The drug was only, the fetus was only exposed for very few weeks in the first trimester. The drug does not cross early in the first trimester. So in this case, and we have done research on that, no congenital anomalies at all or complications of the pregnancy were observed. So in this case, the patient can complete her pregnancy with no major concerns for trastuzumab.
Okay, so may we move from
Thanks.
managing breast cancer